Today's my talk is Physiological Stent Optimization. Is it a new standard? So, in previous studies, since 30 years ago, the myocardial ischemia, its presence and extent and severity has been one of the most powerful predictors for the death or acute MI. Nevertheless, the recent ischemia trial, which compared initial invasive versus conservative management in stable patients with moderate to severe ischemia, there was no difference in the patient clinical outcome up to 5 years of follow-up. However, to me, the PCI or bypass surgery was not a loser. The real problem seems that the conventional ischemia testing plus coronary CT angiogram-based approach may be insufficient to select the right target population of invasive treatment. That's because when we see the likelihood ratio of these non-invasive stress tests to detect the angiographically significant lesion or FFR positive lesions, the probability of having those significant lesions is only around 50%. That means even if you have abnormal result in non-invasive stress test, that finding will match with the angiographic findings only in the 50% of patients. And from the ischemia trial result and the patient-level meta-analysis of the FFR-guided PCI versus medical treatment, we can see a striking difference regarding death or myocardial infarction. In ischemia trial, no difference. However, in the patient-level meta-analysis, FFR-guided PCI had significantly lower death or MI risk. And this data shows invasive physiologic index-guided PCI is more effective to reduce death or MI than non-invasive test-guided PCI. And the ischemia trial, actually the initial invasive strategy had a significantly lower risk of spontaneous MI than medical treatment. However, those difference was diluted by the higher periprocedural MI after invasive treatment. So another lesson is that avoidance of unnecessary PCI, which may cause periprocedural infarction or long-term stent failure, is very important for the patient prognosis. And these two representative registries showed about 20% of patients still have post-PCI FFR lower than 0.80 even after the angiographically successful PCI. So angiographically successful PCI is not same meaning with the ischemia resolving PCI. It is very important to note that physiology-guided PCI significantly reduce ischemic burden. In this ORBITA trial sub-study, the lower the FFR or IFR value, the post-PCI improvement in stress echo regional world motion score index was higher. This means that lower the FFR or IFR, PCI will give you better improvement in the regional world motion score index after PCI. And more recent evidence clearly showed that the benefit of functional revascularization in exercise capacity. In this small study, 21 stable angina patients with functionally significant one-vessel disease was evaluated by supine bicycle exercise in the cath lab. After performing PCI for those very significant regions, patients had much improved exercise duration, and all these coronary hemodynamic indexes were immediately improved after PCI. And the functional complete revascularization improved patient prognosis, including cardiac death or myocardial infarction. In this three-vessel FFR French registry, the functionally complete revascularization was defined by residual functional syntax score. As you can see, patients with functional CR had much lower risk of the MACE as well as cardiac death or myocardial infarction. And the most common reason of functionally incomplete revascularization was low post-PCI FFR even after the successful PCI for the target region. So these results support the importance of post-PCI physiologic evaluation and further optimization of the stented segment. And recent meta-analysis, the patient-level meta-analysis from 14 post-PCI FFR registries evaluated about 4,000 patients. When we analyzed 2-year follow-up data, when the post-PCI FFR was lower, the risk of target vessel failure was higher. And very similarly, cardiac death or myocardial infarction risk was also higher in the low post-PCI FFR group. So suboptimal post-PCI FFR linked with the hard clinical event as well as composite endpoint. And it is clinically important question whether residual angiographic stenosis have prognostic impact. In the angiography-guided PCI, those residual angiographic stenosis has significant prognostic impact. However, if the PCI was decided based on the FFR, the residual angiographic stenosis has no clinical impact at all. And furthermore, after functionally complete revascularization, in which we use the definition of post-PCI FFR higher than post-80, the residual syntax score has no prognostic meaning. Only the post-PCI FFR, namely residual ischemia, has a significant prognostic implication after PCI. So it is very important to minimize the residual ischemia and optimize revascularization result. In this regard, post-PCI FFR, I think this is the gatekeeper for deciding need of further treatment. In this patient, after beautiful PCI in the LAD, the post-PCI FFR was 0.76, and more importantly, the FFR gradient was observed across the stented segment. And I was revealed stent under expansion, and after doing the further dilatation of the stent using non-compliant balloon, the post-PCI FFR was much increased to the 0.89, and the IVUS confirmed the stent expansion was excellent. And in this case, after putting the stent at the mid-LAD, the post-PCI FFR was 0.72, and there was major step up at the distal edge of the stent. And after careful examination of angiogram and intravascular imaging, we noticed that there was stent distal edge dissection. And after covering additional stent, the final post-PCI FFR was much increased, and there was no significant pressure gradient across the distal edge of the stent. And this study evaluated about 500 patients and demonstrated that subsequent intervention based on the post-PCI FFR, such as post-dilatation, additional stenting, or imaging evaluation, these subsequent intervention can further increase final post-PCI FFR result. And the recent target FFR study also showed the residual diffuse disease and suboptimal stent expansion is the main cause of suboptimal post-PCI FFR. And after further optimization protocol, the incidence of final FFR less than 0.80 was significantly decreased using those standardized approach. So this is one of the suggested algorithm of post-PCI evaluation, and I think the post-PCI FFR pullback is the most important step. If that pullback method reveals some focal major step up, we should use intravascular imaging to evaluate the stented segment. After further intervention of the correctable cause, remeasure the post-PCI FFR and pullback, and if you have gradual step up across the stenosis, we can calculate the relative FFR increase, and if those procedure provides you over 15% of FFR increase, we can finish the procedure. However, if that relative increase of FFR is still suboptimal, maybe additional PCI will not give you the satisfactory result because the underlying diffuse disease was the cause of suboptimal post-PCI FFR. So how can we discriminate the focal versus gradual step-up? We can quantitatively transform those FFR pullback tracing into the FFR gradient method, and if those FFR gradient is higher than 0.035, it corresponds with the transstenotic pressure gradient over 15 millimeter mercury. So having those, the objective criteria of the major step-up, two different operators, their judgment about the presence of major gradient was much increased. And when we analyzed the 2-year clinical outcome data according to the visually defined major residual FFR gradient, there was no difference according to the visual assessment. However, when we adopt those objective assessment of major residual FFR gradient, patient with still residual FFR gradient had a higher risk of target vessel failure. And those trend was also same with the patient with the optimal post-PCI physiological result. So we can do better if we can measure post-PCI physiological assessment. So, and lastly, I'd like to show you FFR-guided PCI can improve patient survival in nationwide cohort analysis. Although in the previous trials, there was no difference in the patient mortality according to usual physiological approach. However, when we analyze larger data set in United States and Europe and Korea, a patient treated by FFR-guided PCI had significantly lower mortality than angiography-only guided PCI. And when we analyze the cost effectiveness using those data, regardless of different healthcare system, Korea, United States, and United Kingdom, FFR is the consistently dominant strategy than angio-guided PCI among those 3 different healthcare systems. So personally, I do about 400 PCI per year. To me, those physiologic index has very important clinical meaning because I have very busy schedule in the cath lab, so I don't have much time thinking many things. So in this regard, FFR has clear cutoff value and highest spatial resolution, and suboptimal post-PCI FFR can tell you about the future heart clinical event, and further optimization can improve acute revascularization result further. So this is my final slide. Physiologic index is more accurate than your visual assessment. And to improve patient prognosis, objective and accurate criteria is needed. And suboptimal post-PCI physiologic results are linked with the heart clinical event, and further optimization is very important for the patient prognosis. Thank you.